Hello everyone, welcome to Unacademy. Let's crack NEET PG. I'm Dr. Shilpa Dinesh. I'm a practicing pediatric consultant and an educator in Unacademy. I have an experience of teaching undergraduate and postgraduate medical students. I have done my MBBS and MD from Rajiv Gandhi University of Health Sciences. So today we'll be talking about tuberculosis in pediatric patients. So everything related to tuberculosis in pediatrics will be discussed here. And this is going to be a recorded class. Okay. So now, before that, I would want to talk a little bit about Unacademy. Unacademy is India's largest online learning platform, and also there are a lot of benefits you can avail. First of all, the daily live classes. You can attend these classes every day. So there are various educators in this platform, and they have regular classes happening in this platform. You can attend your favorite educators' classes and engage in discussion, ask your doubts, and the doubts will be cleared immediately in the live chat box. Also, whenever you're preparing for your entrance exam, you need to have a structured course. You have to plan well. Okay, you have to revise beforehand, well before the exams. So all our courses are structured in line with your exam syllabus, and this is going to be a huge boost to your preparation. Also, whenever you're preparing for your entrance exam, you need to evaluate yourself. You need to evaluate what is your strong area and weak area, right? So once you know what are your weak areas, you can concentrate better on those topics. So here in Unacademy, there are a lot of live tests, quizzes, mock tests happening, and this will help you to evaluate yourself and concentrate more on the weaker subjects. Right. So another thing is the unlimited access. So once you subscribe to the subscription, you get access to all the classes. Okay. So if you have missed any live class, you can go back and watch the recorded classes again and again. All this in the comfort of your home, in the comfort of your own device. So I would highly recommend this platform. Using this platform in the beginning part of your preparation will help you a long way. Fine. So now these are the top educators in the platform, and they have regular classes happening. All the 19 subjects required for your NEET PG preparation are taught in this platform. And the ongoing courses, these are the ongoing courses in our platform right now. And as you can see, this is the NEET PG subscription package. So the package varies from 1 month to 2 years. So for the students who are preparing for their NEET PG 2021, who would be writing their NEET PG 2021, the 6 month subscription would cost you 20,000. And using my code Shilpa 10, you will get a 10% discount, and it will come up to 18,000. And especially for the ones who are in their internship and who are in their final year MBBS or the third year MBBS, I would recommend this, the 1 year and the 2 year subscription. So the 1 year subscription costs you around 25,000, and using my code Shilpa 10, you'll get a 10% discount, and it'll come up to 22,500. 2 year subscription is 30,000, and using my code Shilpa 10, you get a 10% discount, and it'll come up to 27,000. So I highly recommend this platform. And as you can see, the rates are very reasonable compared to the other platforms, and will help you a long way. So today's topic, now we'll start discussing today's topic, that is tuberculosis. Right. So tuberculosis is caused by Mycobacterium tuberculosis. So you all know. So who is a reservoir of the infection? So a patient who is suffering from pulmonary tuberculosis, okay, who discharges the tubercle bacilli in the sputum and in the nasopharyngeal secretions. So this is the person who has the bacteria, right? So if the person, this person can spread the bacilli with the sputum and the nasopharyngeal secretion. So a person with the pulmonary tuberculosis, right? So the mode of spread, what is the mode of spread? The inhalation of the droplets of the infected secretion, okay, but there could be a transplacental mode of spread too, but that is very rare. So transplacental this thing is rare. Okay, what are the risk factors? Who are the children who are at very much risk to develop tuberculosis? So firstly, a child who is undernourished, so malnutrition. Okay, children with primary or secondary immune deficiencies. Right, and especially people who are in the institutional settings, like nursing homes, homeless shelters. So institutional setting, because it is always crowded, right? And also in the hospitals where you might come across a lot of tuberculosis patients. So institutional setups. Okay, so these are the people, and wherever there is immunosuppression, okay, these are the people who are at a high risk of developing tuberculosis. Now, so what is the pathology? Okay, so how does this mycobacterium tuberculosis cause disease in us? So first of all, you inhale the inhaled tubercle bacilli will get lodged in the pulmonary alveoli. So now once it's in the pulmonary alveoli, what will it do? It will cause, this will eventually cause inflammation, inflammation, which leads to hyperemia and congestion, right? So this will cause, so once the tubercle bacilli goes to the pulmonary alveoli, it will cause inflammation. So now what happens? Now there is this bacilli in the body, that is a foreign pathogen, right? So now all the polymorphonuclear leukocytes will try to infiltrate. Okay, so now all the polymorphonuclear cells will come to try to destroy the tubercle bacilli. If you as a host are very strong, then this the host if the host resistance is with the inflammatory exudate around the primary focus is absorbed, and only a caseous area will be inspissated. So if the if the resistance is good, then there will be a caseous formation, caseous area, right? So this caseous area will eventually heal by fibrosis and calcification. Okay, so now imagine if the immune system is weak. Immune is weak. That time what happens, especially the cell mediated immune system. So if it is weak, what happens? The bacilli will further multiply. And then it will extend to the other areas. Okay, it will go to the other contiguous areas. And it can lead into a serious complication of tuberculosis. Fine. So now so in the pathology, you should know about the primary progressive primary disease. So progressive okay, so the progressive primary disease. Okay, now there will be a, what happens, there will be a primary complex, right? You know that there is a primary focus, so that forms the primary complex. So now from the primary complex, it can worsen, the tuberculosis can worsen and can lead to a progressive primary disease. So if it's a progressive primary disease, what will happen? So the primary complex, the primary pulmonary primary complex, that will, instead of calcifying, it will enlarge steadily and develop into a large caseous center. Okay, so there is already a primary focus, right? So it should be the caseous, what caseous matter, whatever was formed, it has to heal. But instead of healing, what happens? It develops into a large caseous center. Now in this center, what happens? The center will liquefy and it will empty into the adjacent. So now just imagine this is a hard ball. So if the center will liquefy, and then it will what is it, reach to the adjacent bronchus, right? So it will reach the center will liquefy and it will go to empty into and empty into the adjacent bronchus. So as a result, what happens? So now this entire caseous ball has liquefied. So now that area is empty, right? So that becomes a cavity. Okay, so that becomes a cavity. Okay. But you know one thing, cavity is not very common in children. Okay, so cavitary lesions are not very common. So now what happens? Now the bacilli may spread. So once it enters the bronchus, it may spread to the other parts of the lung. So it might spread to the other lobe, or the entire lung might be involved. So this might further lead to, so now it liquefies, right? So this may further lead to bronchopneumonia or lobe consolidation. Okay, so sometimes what happens is even the lymph nodes are enlarged, right? So one second. Yeah, so sometimes what happens, even the lymph nodes are enlarged. So if the lymph nodes are enlarged, so this will compress the neighboring airway. So if the lymph nodes are so much enlarged, that can compress the airway. And as a result, so when you compress the airway, so there can be a ball valve effect. Okay, so ball valve effect, what will happen? There will be an incomplete compression of the airway. Okay, and this will lead to trapping of the air distal to the obstruction. So the air is not able to go out. Okay, so that will lead to compression of the airway, will lead to ball valve effect. Okay, effect. So in because of the ball valve effect, the, there is incomplete obstruction to the airway, and as a result the air is not able to move out, and the air is trapped distal to the obstruction, and as a result this will lead to emphysema. Okay, so sometimes what happens, there will be enlargement of the paratracheal lymph nodes. So if the paratracheal lymph nodes are enlarged, okay, just imagine if the paratracheal lymph nodes are enlarged, so then it will lead to stridor. It can lead to stridor. It can cause respiratory distress. If the subcarinal nodes are involved, lymph nodes are involved, then it will lead to it cause so what is it? Obstruction of the esophagus, which can lead to dysphagia. Okay, and if the obstruction is complete, if the obstruction, so this is an incomplete obstruction, right? Okay, so if there is a complete obstruction, if there is a complete obstruction, it can lead to atelectasis. Fine. Yeah, so this is how, if these are the features if tuberculosis, when the lymph nodes are enlarged, and this is how they can cause various symptoms. Fine. So next, so now how can, what happens when there is a bronchial obstruction? So one thing, so how, what are the outcomes? So one thing, it can completely resolve, and the chest the it will resolve, and the chest expansion will improve, and the x-ray findings also will resolve. Sometimes what happens, there is disappearance of the segmental lesions, but sometimes it can lead to scarring and progressive compression of the lobe or segment, leading to bronchiectasis. So now what happens if there is a lymph node which is caseated? So if there's a caseated lymph node, okay, now it can erode into the bronchus. Okay, erode to the wall of bronchus, and this will lead to tuberculous bronchitis or the endobronchial tuberculosis. Fine. So that time what happens, the discharge of this, the discharge in this tuberculosis can from the lumen, it can lead to bronchial dissemination. So all this discharge can enter the entire part of the lung. So if there is a lung which lymph node which is affected by tuberculosis, that can erode the wall of the bronchus, and in turn lead to tuberculous bronchitis and endobronchial TB. So this is one of the way of how the tuberculosis spreads in the body. Another another way is by the hematogenous spread. By the hematogenous spread. So if there is a hematogenous spread, what happens? So now there is an infected lymph node. So hematogenous dissemination occurs from the infected lymph node. So there is an infected lymph node occurring. So this results in the foci of infection in various organs. Okay, so if the host immunity is good, the foci is contained and the disease won't occur. But if the immunity of the child is decreased or in a severely malnourished child or immunocom, this will lead to a activation of these metastatic foci. So what happens? So there is a lymph node which is infected. So because of the blood spread, there will be various metastatic spots. Okay, but since the the immunity is good, there won't be any disease. But if the immunity is low, these metastatic foci will cause the development of the disease. So there will be infected lymph node, which will lead to uh, hematogenous spread. Okay, so now what happens in case of pulmonary tuberculosis? So in pulmonary tuberculosis, if there is because of endogenous reactivation, so if there is a reactivation of the foci, the commonest type for this disease, so if it is because of the reactivation of the foci, okay, in pulmonary tuberculosis, it is because of the reactivation. Because of reactivation, the most common site for it to happen is the apex of the lung. Okay, here in the apex of the lung, the blood flow is little slow. Okay, so the best best area is, best common site is apex of the lung. So this lesion is called as the pull lesion. Puhl, pull lesion. Okay, so why does it happen commonly in the apex of the lung? Because the blood flow is very sluggish to the apex. Okay, and when there is a primary lesion, okay, if there is a primary lesion, it might take a year for miliary and meningeal tuberculosis to occur. So this is one of the complications. So now coming to the clinical features. So as you so the incubation period is 4 to 8 weeks. Okay, so the onset is very insidious. But in case of miliary tuberculosis, miliary tuberculosis can be anywhere, like it could be in the entire lung. So miliary tuberculosis, the presentation is acute. Okay, so the miliary tuberculosis presentation is acute. Now, primary infection usually passes. So if there is a primary infection, it will just go off. But there is latent infection. So whenever our immune system is weakened, this mycobacterium will get activated. So there will be so either children will have asymptomatic infection. Okay, so when they have symptoms, so first thing you need to know, when a TB child has symptom, you have to ask for fever. So the pattern of fever you have to ask, and then you have to ask for anorexia, or if there is severe weight loss. So if a weight loss of more than 10% of the normal weight, then you have to consider have a suspicion for tuberculosis. Okay, so generally in children, cough is not seen much. Okay, cough is mostly seen in a very advanced disease. Okay, in children, but these children might present with a dry cough. Okay, if these lymph nodes are causing obstruction to the airway, they can present with dry cough. Okay, so now coming to the in the primary disease, the progressive primary disease. So how will the progressive primary disease present? So progressive primary disease. So in a progressive primary disease, this is because of the progression of the primary disease. So the child will have a primary disease. It may be symptomatic or asymptomatic. But how does a progressive primary disease happen? So here what happens, a child will have high grade fever and cough. Okay, now this cough, the expectoration might be bloody. So there might be hemoptysis. okay, especially in the advanced state of tuberculosis. So next, so there is in children again the cavitatory lung lesions are very rare, but it's common in a adult cavitatory lesion. But in children, how? If there is an endobronchial tuberculosis, they will present with fever and persistent cough, especially if there is endobronchial tuberculosis. They'll have persistent cough. So now based on the compression, so they can have dyspnea, wheezing, and they could be cyanosis. So based on the compression of this airway, they can present with various symptoms. So now coming to miliary tuberculosis. So how is miliary tuberculosis happening? So this happens because of the hematogenous spread. Okay, and there will be multiple foci. So I told you there is a infected lymph node through because of which there is spread of the foci to various parts of the body, and when your immune is suppressed, this foci which were latent will get activated, right? So this is common in infants and young children. Okay, so now as I've told you here, the symptoms are sudden, the abrupt sudden onset of symptoms. Okay, the clinical feature will depend on the virulence of the organism and the organ which is involved. Okay, depends clinical features depends on the organism and the site of involvement. Okay, so these children can first when you think of the systemic presentation, so they'll have high grade fever, they'll have dyspnea, they'll have cyanosis, they'll have altered sensorium. Okay, and these patients will show hepatosplenomegaly. So it is disseminated. They can show hepatosplenomegaly. So when a child with hepatosplenomegaly comes, you have to keep it. And if there is a high grade fever, a history of weight loss, hepatosplenomegaly is present, miliary tuberculosis should be kept in mind. Okay, and in 50%, 50% of these children can have choroid tubercles, and 20% of these children can end up having meningitis. Okay, yeah. Now coming to the extra-thoracic tuberculosis. So what are the extra-thoracic tuberculosis? Where and all can it affect? So the main thing in children, it is the superficial lymph node and the central nervous system. The other areas are, there is abdominal tuberculosis, gastrointestinal, genitourinary tuberculosis, cutaneous, congenital. But in children, the most common extrathoracic tuberculosis is the superficial lymph node and the central nervous system. So if there is tuberculosis of the lymph node, how does it happen? For there is history over here. You have to ask for history of drinking unpasteurized milk. Okay, or if there would be a primary disease, and that disease would have extended and could have caused the lymph node tuberculosis of the lymph node, right? So if there was an extension of the primary disease. Okay, so now, or if there was abdominal tuberculosis, okay, upper lung, that could lead to the extension. So now these lymph nodes, one of the ways what you see is here in the lymph nodes will be matted. Okay, they'll be fixed to the surrounding, so you cannot move it. Generally a lymph node will be easily movable, so these lymph nodes will be fixed to the surrounding structures. Okay, so most of them will have spontaneous resolution, but most of them, but treatment is still very important, because if there is untreated lymph node tuberculosis, they can lead to caseating. So if untreated, it can lead to caseating, necrosis, okay, and there could be rupture of the capsule, okay, it can spread to the adjacent nodes, okay, and the skin, and eventually it might lead to the formation of a sinus. So they lead to the formation of draining sinus tract. Okay, so remember this, always you should know the history of consuming unpasteurized milk, or extent if there was a primary disease, that could be the reason why the child is having a superficial lymph node which is affected. Okay, so if this child is not treated, most of the time there is remission, but if the child is not treated, then it can lead to caseous necrosis. The lymph node, the capsule might rupture, it might spread to the adjacent nodes, it might spread to this overlying skin, and eventually there will be a draining sinus tract. Okay, so now coming to the central nervous system. So its central nervous system is the most serious complication of tuberculosis. Okay, okay, tubercular meningitis is the most serious complication. So now what happens? Here there will be a formation of caseous lesion in the cerebral cortex. So there will be a caseous lesion in the cerebral cortex or the meninges. So how did it happen? How did this caseous lesion go to the cerebral cortex? That is because of the lymphohematogenous spread. Okay, because of the lymphohematogenous spread, there was caseous lesion in the cerebral cortex and the meninges. Now, so here what happens? In infants and children, there is rapid progression of what are the symptoms. So rapid progression, there will be hydrocephalus as a result. It could be hydrocephalus, especially young children, young infants, young children. So in young children, so it will be rapid progression to hydrocephalus. There will be hydrocephalus. There could be raised intracranial pressure. Okay, there and as a result, they can have seizures. Okay, they could have change in their tones. There could be hypertonia. Okay, but what happens in older children? How will these older children present? So older children, okay, they'll have fever, headache, irritability, central nervous system symptoms. Okay, so now how the disease will eventually progress, there will be lethargy, there will be seizures, there will be nuchal rigidity. Okay, there will be focal signs will be there. So the final stage in a central nervous system, if you don't aggressively treat, in the final stage the child can go into coma. There could be hypercorticate or decerebrate posturing, sorry, decerebrate decorticate posturing, and then eventually death. Okay, so always when you have a doubt that this child could have a central tuberculous meningitis, even before the diagnosis is confirmed, you have to do an early institution of therapy, because this child can eventually die if the treatment is not given at the right time. Okay, so tuberculosis of the abdomen. So when there is tuberculosis of abdomen, this is how this occurs because of the hematogenous spread. Okay, spread from the lungs. Okay. So, so sometimes what happens, if you swallow, if the patient has primary disease and you swallow your own sputum, that also can cause abdominal tuberculosis. So, swallowing sputum when having primary. Fine. So that is these are the two ways you can end up having abdominal tuberculosis. So they'll be initially asymptomatic. So when they have symptoms, so if they have symptoms, so they'll be asymptomatic. So generally a diagnosis of abdominal tuberculosis may take quite some time. So no one thinks of abdominal tuberculosis straight away, right? So initially they'll be asymptomatic. When they have symptoms, they can have a toxic look. There is toxemia. There could be a colicky abdominal pain. Okay, there could be constipation. There could be vomiting. Okay, and when you feel the abdomen, you have this doughy doughy abdomen feel. So a dough, so how you touch a dough, when you make a dough, the dough, when you feel the dough, the same feeling happens when you touch the abdomen, doughy appearance, doughy feel. Okay, so but the abdomen is also tense abdomen is tense. Okay, now sometimes what happens, the omentum is rolled, and the omentum may be rolled, and the abdominal lymph nodes might be enlarged. Okay, and there could be spleen, and the liver might be palpable. Okay, so this is how a child with the extrathoracic tuberculosis will present. So now coming to the diagnosis. So diagnosis, first thing is asking history. So always you need to ask history. You have to check for the clinical features. Okay, you have to get a chest X-ray, and you have to get a Mantoux testing done. You have to ask for history of contact. So now, okay, this is very important, especially in children, because for children you have children just can't get tuberculosis like that. So there has to be a history of an adult. So always ask for history of contact in a child who has tuberculosis, or whom you are suspecting to have tuberculosis. So what is a history of contact? So now you have to remember this. So a contact history for tuberculosis is uh, a child. So a contact, hmm, a contact, okay, is defined as a child who lives in household with an adult, okay, who is taking anti-tubercular treatment, or having taken, who has already taken, so one who is taking the anti-tubercular treatment, or having taken, okay, such therapy or such treatment in the past 2 years. Okay, so always a child who, if the contact is someone, if the child is living in a house where there is an adult who's taking an anti-tubercular therapy, or having taken the treatment in the past 2 years. So this is very important. So remember, so it's not just a household who is living with them, living and is taking tubercular treatment. So even if who has completed taking in the past 2 years, also comes under the history of contact. Okay, so what are the laboratory tests? So whenever you are testing for pulmonary tuberculosis, you have to divide into two categories. Okay, so what are the divided into? So one is the demonstration of the based on the Mycobacterium tuberculosis, and the second is the what is the host response to the Mycobacterium tuberculosis. Okay, so this is first component. It could be because of the tuberculosis. So there are two types. One is based on mycotuberculosis and its components. Another thing is host response to the Mycobacterium tuberculosis. Okay, so now when it comes to Mycobacterium tuberculosis, how can it be demonstrated? So one is the Zeden scale, Zeal-Nielsen scale, right? So Zeal-Nielsen scale is a acid fast staining. So you know tubercle bacilli is a acid fast bacilli. Okay, so acid fast. So what are the special stains? So for one of the examples for special stains is when there is a fluorescence microscopy happening, that time you can use auramine, rhodamine stain. Okay, and when it comes to culture, the best medium for Mycobacterium tuberculosis is LJ medium, that is the Lowenstein-Jensen medium. right? So another very important thing which has taken the made the diagnosis of tuberculosis very easy is the cartridge based nucleic acid amplification test, which is also called as the CB-NAT. So this you have to keep I mean, you have to read a lot about this, because this is a very important test right now in the diagnosis of tuberculosis, and a lot of questions might come from this topic. Okay, so if you're reading I mean, when you're reading tuberculosis, you have to give more importance to CB-NAT. Okay, so now the staining. When you come to the staining, I've told you it is a Zn stain, which is very important when we are diagnosing this thing. What is it? Tuberculosis. Another thing is fluorescence microscopy. So over here is the auramine, rhodamine stain, right? So now the best specimen in children. So it's very difficult to make a child cough out and get the sputum, right? So the best specimen in children, in child, is the gastric aspirate. Okay, early morning gastric aspirate. So this is taken via the nasogastric tube. So you put a nasogastric tube, and the first thing in the morning you have to get the gastric aspirate. So this is the best specimen in a child. Okay, but if you have to get a very good result, you have to take two specimens. Okay, two specimens in the consecutive days. Okay, so now coming to the culture, as I've told you, the LJ medium is the best medium for Mycobacterium tuberculosis. It will tell you the colony morphology. So it will also tell you the growth rate and the pigment production. But the only problem with this is the limitation. The limitation The limitation is it takes 7 to 10 weeks for the results to come. So it will take 7 to 10 weeks of incubation. So only then the growth happens. So this is very late for us to treat a child with Mycobacterium tuberculosis, right? So now that is why what has happened, there is another thing which they use is the microscopic. So remember this is very important. Okay, there is microscopic examination of thin layer culture plate. So thin layer culture plate, right? So they examine a thin layer culture plate, and this will help in detecting the the microcolonies of Mycobacterium tuberculosis by 7 days. After 7 days. But what happens is the yield of this is only 30 to 70%. If you're using a gastric aspirate. So now what has happened, now because of all these limitations, there has been a new mycobacterial growth system which has been formed. So all this has been replaced by, remember this, it is replaced by something called as the MGIT system. Okay, so the MGIT system is nothing but the mycobacterial growth indicator tube, right? Yeah, so in this system what happens, the culture is positive in 2 weeks, okay, but the final result comes in 6 weeks, but in 2 weeks you will get the result. So over here I said the sensitivity is not good, so now we've used the MGIT system, that is a mycobacterial growth indicator tube. So remember this, the LJ medium is replaced now by the mycobacterial growth indicator tube. So now coming to the cartridge-based nucleic acid amplification test, which is called as the CB-NAT, right? So now this is a PCR test. It's a real-time PCR. Okay, so this is right now used by most of the people, most of the physicians and the pediatricians for the diagnosis of pulmonary tuberculosis. Okay, so you get the result by in less than 2 hours. Okay, now this will another importance of this CB NAT is it will tell you, it will give us a result or give us the what is it, information on the resistance to rifampicin. It also gives the information to the resistance resistance to rifampicin. So this is very important. So when you know there is resistance to rifampicin, you can manage, you can change your treatment guidelines, right? So that is why CBNAT is very important, and this has a high specificity. So even if it is gastric aspirate, okay, it has a specificity of 60, it has a sensitivity of 60 to 70% and a specificity of 90 to 100%. But this CBNAT has a lower sensitivity and specificity in extrapulmonary tuberculosis. So it's very good for pulmonary tuberculosis, right? Next, if there is any latent infection, what are the methods you can use to diagnose there is a latent tuberculosis infection? So from a long time, only the Mantoux test was done. Okay, Mantoux test. So now there is another new test called as the IGRA. That is the so that is the interferon gamma releasing assay. Interferon gamma releasing release assay. Okay, so now in this there are two types. That is the quantiferon quantiferon whole TB test. This is very important. Remember this whole TB test. And then another is called the ELISpot. Okay, so what happens is over here it will estimate the component of the cell mediated immunity. Okay, immunity to the mycobacterium tuberculosis, and based on how much you quantify the interferon gamma, okay, uh, that is released from the sensitized lymphocytes in the whole blood, that is incubated, and with the specific antigen, specific bacterial antigen of the bacterial species. So basically you quantify the interferon gamma released from the sensitized lymphocytes to the which is sensitized by the bacteria. Okay, so this is an assay of interferon gamma. So there are two types. One is the quantiferon gold TB test, another is the ELISpot. So next, coming to the tuberculin test or the Mantoux test. Okay, so one thing is you have to remember this is a intradermal test. This is done on the volar aspect of the forearm. Okay, so basically you give around 5 TU, 5 TU or TTU based on the what is it, purified protein derivative. So 5 TU or 2 TU based on the protein, what is it, protein derivative, purified protein derivative. You give the intradermal Mantoux test. So after around 48 to 72 hours, around 48 to 72 hours, you measure this wheal or the swelling, the induration. Okay, measure the induration. So the induration should be measured transversely. So now if this is the hand, so the hand, okay, and this is the forearm, and you have given the what is it, the Mantoux test, and the induration happens like this. So okay, so now you have to measure it transversely. Okay, transversely against the longitudinal axis of the arm. So it should be transverse to the longitudinal axis of the arm. Okay, so always it should be transverse, not like this. It should be transverse, remember. So the measurement should be transverse. So So now what happens? How do you what is it interpret? So if the Mantoux test, the induration is less than 10 mm, then there is no active disease. If it is 5 to 10 mm, it is borderline. That means if it is a immunocompromised patient, okay, then you take it as positive. Or if it is a contact with an adult patient who is sputum positive tuberculosis, take it as positive, okay. But if it is more than 10 mm, okay, more than 10 mm, so this is borderline. So though less than 10 mm, no active disease, but if it is between 5 to 10 mm, and if it is an immunocompromised patient, take it as positive, okay. If it is more than 10 mm, it is active disease, that is, it is positive, okay. So this is how a Mantoux test is done. So this is how you should remember. It's an intradermal test. It is done on the volar aspect of the forearm, and the once you give the purified protein derivative based on the purified protein derivative, it is either 5-TU or 2-TU, that is tuberculin unit. Then after 48 to 72 hours of the injection, then you measure the induration transversely to the longitudinal axis of the forearm. So how do you interpret? If it is less than 10 mm, it is no active disease. If it is 5 to 10 mm, it is borderline. If it is more than 10 mm, it is an active disease. So when you get a Mantoux test, it could have false negative or false positive results. So why is it? How is it false negative? There could be various infections in the body. It could be viral infections, bacterial infections like measles, mumps, chickenpox, enteric fever, leprosy, pertussis. Okay, so these can cause negative results. If there is chronic renal failure, liver failure, Hodgkin's lymphoma, chronic leukemia, corticosteroid therapy, immunosuppressants, newborn or an elderly patient, okay, if you have given live vaccines. Now if there is any problem with the tuberculin, okay, the purified protein derivative, so if it is exposed to light heat or chemicals, if it is contaminated, if there is improper dilution, that also can cause false negative. But if the technique is wrong, if you have given very little agent, or if it has become a subcutaneous injection, or you have taken the protein what's it, PPD, and you have not given it immediately. So if you've kept for some time, so the delay in giving the injection, so that also can cause false negative. Injection is close to other skin tests, or if there was error in reading, okay, it is not read by an experienced eye, okay, so that could cause false negative. What were the false positive results? So if there is an infection because of an atypical mycobacterium, if there was BCG vaccination given, then there is infection at the site of the test, so all this could cause false positive results. Okay, so there is something called as BCG test. Okay, so when you vaccinate, you give the injection on the when you vaccinate in an individual who is suffering from tuberculosis, there is an accelerated response. So accelerated response to the vaccine in a person with TB is that time the BCG test is positive. So there is an induration of more than 5 to 6 mm in 3 days, after 3 days. Okay, so this is called as a positive reaction. Okay, so now we'll get a radiology. Okay, so now radiology is very important in the diagnosis of tuberculosis, you know. So chest x-ray is very important for pulmonary tuberculosis. Also in extra pulmonary tuberculosis, you have to get a chest x-ray because to see if there was any primary lesion. Okay, so that will support the diagnosis of an extra pulmonary tuberculosis. For pulmonary tuberculosis, it is very important to confirm, but for extra pulmonary tuberculosis, it will help in supporting the diagnosis. Okay, so in the chest x-ray, okay, what you typically see is a pulmonary primary complex. Okay, it will be unifocal and it can be homogeneous. So you can sometimes see enlarged lymph nodes. Okay, that is seen in the near the hyla. Okay, near the hylae or the right paratracheal region. There could be adenopathy. Okay, now sometimes what happens in the progressive pulmonary disease, PPD, progressive pulmonary disease, there could be heterogeneous patches, consolidation. So there could be consolidation Okay, there will be a lot of consolidations. They don't have a very good, I mean, the margins are poorly demarcated. Okay, so that can be seen. If there is bronchiectasis, there could be features of bronchiectasis in a patient with the what is it, pulmonary tuberculosis. There could be collapse. You can see a cavity, not in children, not very rare in children, but you can see a cavity. There could be pleural effusion, especially when there is a miliary tuberculosis. Okay, so these are very important. So sometimes what happens is the chest radiograph may be normal, but lymphadenopathy is detected. So when you get a CT done, you might get a what is it, lymphadenopathy. So that is why, what are the this thing, what do you see in CT? So in CT features, so what do you see in CT? So in CT, what happens, there is the lymph nodes are seen, and they, you can see a peripheral enhancement of the lymph node. Okay, so now what happens, you can see the inside is low attenuation, but the peripheral enhancement of the lymph node is seen. Peripheral enhancement of lymph node. Okay, now all these miliary nodules, central lobular nodules, all that is seen in CT. Okay, when you get a contrast MRI, okay, contrast MRI is very useful when there is meningeal tuberculosis, CNS tuberculosis. Okay, this will help in localizing the lesion, and it will show you the meningeal enhancement, if there is any brainstem lesion, if there is any ventricular dilatation. So that's why our MRI is important when you're diagnosing tuberculosis of the CNS. Okay, so now what is the approach for the diagnosis of tuberculosis? Okay, so first of all, you need to know, when do you suspect a child with tuberculosis? So when there is fever or cough, fever or cough, fever and or cough, or and, for more than or equal to 2 weeks. If there is loss, plus or minus loss of weight, or no weight gain, you can consider even that, especially in children, or no weight gain. Okay, history of contact. So history of so this is for pediatrics. Okay, history of contact with someone who has a who was suspected or who was diagnosed with tuberculosis. Okay, then you get a chest X-ray, and a Mantoux test. Okay, now if the chest X-ray is suggestive of TB, suggestive of TB. If the chest X-ray suggestive of TB, then you get a send the gastric aspirate, you induce sputum, you send for GNS2, that is CB-NAT and all that. Okay, you send for CB-NAT. Okay, then if it is positive, or if it is negative. So if it is positive, you should assign the category. Okay, assign the category. Which category? Category 1 or category 2? Tell the category and give the treatment. Okay, start the treatment. Now it is negative, so you repeat X-ray, repeat chest X-ray after 2 to 4 weeks. Okay, now if the chest X-ray is suggestive of tuberculosis, then a positive tuberculin test, then you again assign the category and treat the patient. Okay, so CB-NAT, that is gene expert, is very important. Okay, or the what did I say, MGIT. What is MGIT? Mycobacterial growth uh, growth incubation plate, indicator plate. Okay, mycobacterial growth indicator plate. So either the CB, so you send the gastric aspirate or the induced sputum for CB-NAT or the gene export or the MGIT. So if it is positive, you categorize the patient and start the treatment. If it is negative, repeat the chest X-ray after 2 to 4 weeks. And if it is again negative, then no tuberculosis. If it is positive, then assign the child the category and start the treatment. So now here you have done the chest X-ray and Mantoux test, but it is not suggestive. Not suggestive. You give antibiotics, but the symptoms do not resolve. No symptoms do not resolve. That time what do? You again send the gastric aspirate and all that for the smear. You send for TB-NAT and MGIT, similar. Okay. And what is it? Smear. So now over here, if it is positive or negative, if it is positive, treat or send the category and treat. If it is negative, repeat X-ray after 2 to 4 weeks. If it is positive, treat. So this is how you do. This is very simple. So nothing. So now there are very lot of tests which helps us in the diagnosis. So when the X-ray suggestive of tuberculosis, get a CB-NAT, send a smear, and all and for the mycobacterial growth indicator tube, you send the gastric aspirate or the induced put. So if it is positive, assign the child to the category and start treatment. If it is negative, after 2 to 4 weeks, again get an X-ray, because sometimes the X-ray changes might be a little late, right? So then you, if it is positive, assign. If it is negative, if the chest X-ray or the Mantoux test is negative, give an antibiotic for 7 to 10 days. If there is no symptoms, if the symptoms resolve, well and good. But if the symptoms do not resolve, then you have to send for gastric aspirate. You have to send the induced sputum for CB-NAT, smear, and the MGIT. If it is positive, same thing goes. So now the categories have been changed. So in pediatrics, there are only 2 categories. So you have to remember, these are new things. This might come for your exam. Okay, new, advanced, I mean latest. Okay, so the category 1 and category 2. Okay, so whom do you say it's category 1? If it is a new sputum positive pulmonary tuberculosis, if it is a serious extrapulmonary tuberculosis, or an osteoarticular tuberculosis, genitourinary tuberculosis, CNS tuberculosis, or a pericardial tuberculosis. So it could be either the progressive pulmonary primary complex or the progressive pulmonary disease. Okay, it could be tuberculosis of the lymph node, pleural effusion, abdominal tuberculosis. So what do you do? So the treatment also has changed. So now it is 2-HRZE plus 4-HRE. Okay, now ethambutol is also added so that we prevent the chances of rifampicin resistance. That is why ethambutol is added now. Okay, so before it was 4-HR, right? So now it is 2-HRZE plus 4-HRE. Okay, it's a 6 months thing now. Okay, next is the category 2. If there is a relapse, so even after treatment there is a relapse. Okay, there is treatment failure or the return after default. The patient is not taking the treatment properly. So that time you have to give 2-HRZE plus 1-HR, 2-SHRZE. So remember, all the 5 drugs are there. So 2-SHRZE for 2 months, then 1 month of HRZE, then 5 months of HRE. So totally it is for 8 months. Okay, so another important thing is when you have severe forms of tuberculosis, especially the CNS tuberculosis, a dose of corticosteroids will help in the management. So the outcome is better. Okay, also there is in case of pericardial effusion also, corticosteroids has given very good results. Okay, so we give prednisolone. So now if a child is born to a mother with tuberculosis, what do you do? So transplacental transfer of the disease is very rare, but it can still happen. So when a child is born to a mother with an active tuberculosis, what do? You have to screen the child. You have to get a tuberculin test and you have to get an X-ray. Okay, if it is negative, you have to start the child on INH prophylaxis. Okay, but if the child has features of tuberculosis, then you have to give 4 medications, that is isoniazid. If it is positive, you have to isoniazid, rifampicin, and ethambutol, that is HRZE, that is given for 2 months. Then the same thing, then HRE is given for 4 months. So if the child is positive, if the child is not positive, if the child is negative, if the child is born to a mother with tuberculosis but is negative, then you have to give INH prophylaxis, that is given for 6 months. So the dose for INH prophylaxis is 10 mg per kg per day. Okay. Now the management of a child in a contact with an adult with tuberculosis. So now if the child is less than 5 years who is in contact with an adult with pulmonary tuberculosis should receive an INH prophylaxis. Okay, so same thing, the dose is 10 mg per kg per day for 6 months. So before starting INH prophylaxis, you have to rule out if the child is having an active disease or not. Okay. Fine. So now, how do you monitor the child? So, if how do you monitor the child if the treatment is doing well or not? So, first of all, you have to see there are three things. So, one is the clinical criteria, then there is a radiological criteria, then there is a microbiological criteria. So, the clinical criteria is what? So, when the child starts responding to treatment, like the clinical features improve, the child should receive at least 2 to 4 weeks. Okay, then you have to call this child every 2 to 4 weeks initially, and then every 4 to 8 weeks to see if the symptoms are improving. So how do the symptoms improve? So there is weight gain happening, then the chest findings, so there would have been lot of crepitations, there could be bronchial breaths, so the chest findings will also improve. And also the reason why we call every 2 to 4 weeks, okay, that is because to see if the child is compliant with the medicines. So if the compliance is not there, the relapse rates are high, okay, so then again you will have to continue. So if there is no now what happens, so the child is coming to follow up with you but you do not see any satisfactory response. So that time what you should do is you should review, should ask for the compliance and everything, but everything else is fine but still the child is not responding, then it could be a resistant tuberculosis. Okay, so then the following should be considered. So when it is radiological, what is radiological criteria? So what happens first, always the clinical improvement happens, then there is radiological improvement. So after 8 weeks of therapy you get a x-ray done. Okay, so now what happens if the child, this x-ray findings are improving, then it's good. If there is if there is delay in what is it, radiological change, or if there is delay in clinical features, what you do is you prolong the intensive phase by 1 month. Okay, so that is, then you slowly, then you can go for continuation phase. But even after that there is no improvement, then again that means it is drug resistance. Okay, so this you have to keep in mind. So that is why monitoring of the therapy is important, because sometimes these children might present with resistant tuberculosis. So now one more thing what you have to remember is childhood TB is paucibacillary. Fine. So sometimes what happens, you have a microbiological positive tuberculosis, so you have to get another repeat sample at 2 and 6 months to see if the microbiologically it is tuberculosis negative, microbiologically negative. Okay, so this is very important. So now when a child, how do you suspect a child to have drug resistant tuberculosis? So one is if the child has been in contact with a adult with tuberculosis who was having drug resistant tuberculosis, then you should suspect. So an adult contact with adult with drug resistant TB. Okay, irregular treatment or recent death, if there is death due to TB, if the child is not responding to the therapy, condition deteriorates. Okay, you see new lymph nodes, okay, deteriorate. So these are when you suspect the child to have drug resistant tuberculosis. So this was for today's class. So we have done a very detailed discussion on tuberculosis in pediatric cases. So this has been like we have told how is the spread, the epidemiology, the pathology, clinical features of various types of tuberculosis, how do you diagnose. So the very important thing is a cartridge based nucleic acid amplification test, and in the culture right now the LG medium is being replaced by the mycobacterial growth indicator test. Okay. Okay, so what I've told, the laboratory test should be divided into two categories. One is based on the properties of Mycobacterium tuberculosis, and other is the host response to the Mycobacterium tuberculosis. So again, culture, staining, and cartridge based nucleic acid amplification tests and this IGRA and all are very helpful in the testing. So now, then comes the tuberculin test. You should know what are the false negative results and what are the false positive results, and you should know the radiology findings. Okay, so radiology findings, I will be showing few pictures of tuberculosis, chest X-ray, X-rays of tuberculosis in the quiz session. That will be on Saturday. Okay, another thing, the approach of diagnosis is very simple. I don't think you have to rack your brain a lot. So this is very simple. This is very important if you have a clinical scenario coming. Okay, so basically, okay, I will have a clinical scenario also happening, and you should remember the new thing. What's happened is the categories are only two: category 1 and category 2, and the treatment regime also has been changed. So that you should be keeping in mind. Okay, so this is for today. So good luck. I mean, you have to be reading these recent topics. The recent guidelines of tuberculosis is very important. Okay, so you should remember recent guidelines. So, okay, so this was for today's class. So tomorrow we'll be talking about congenital pediatric infections. So it will be a short class. And today at 4 p.m. in the subscription platform, I'll be starting my neonatology session. Okay, so kindly tune in for the class, and if you're subscribing to the subscription, use my code Shilpa10. You will get a 10% discount. So study well, discuss with your study partners. It will help you remember the topics better. Okay, so this is for today. Good luck and study well.